So I also want to have a little round of applause here for Dr. Daniel Sturman, because Dr. Sturman was actually the catalyst for us thinking about getting into funding clinical trials. It was stemmed from a conversation we had at a small group meeting, and Dr. Sturman is really one of the thought leaders in this disease and really has helped me to sort of clarify in my mind some of the directions that we need to lead in. So Dan, thank you very much for your help. So you're both pulmonologists, am I correct?
Yes.
Okay, so we have two pulmonologists who have really, you almost model more of what we see in the UK, where you have the pulmonary specialist leading a lot of the malignancies. And here you really play a very key role in mesothelioma, and a unique role. We don't usually have a pulmonologist so involved with the medical aspects of a malignancy. So I'm wondering, in terms of clinical trials, you're both involved in clinical trials. Tobias, what is your interest in clinical trials? Where is your focus today?
So my background is obviously, like Mary said, I'm a pulmonary physician. I'm also interested in immunology, and so my interest is really cancer immunotherapy and viral therapy of malignancies using oncolytic viruses. And the clinical trial that I'm currently involved with actually uses the measles virus, which was mentioned in one of the previous presentations as an oncolytic virus, and we are administering this virus directly into the pleural space using a Pleurex catheter, with the hope that the virus will potentially directly kill tumor cells by recognizing them better than the surrounding normal cells, and that the virus might also function as a vaccine, triggering an anti-tumor immune response as an additional effect here. And our study is currently a phase 1 study, which is fairly early in its development, and that's what my clinical trial involvement is at this time. Certainly, as Mary pointed out, as pulmonologists, we are typically more involved at the beginning of the disease, specifically diagnosing the disease, staging the disease. But from my perspective, I think it's also important that we follow through and are involved in the therapeutics of the disease.
Mm-hmm. Dan?
So I come from a very similar background as Tobias. My background is as a pulmonologist. I also am one of the pioneers in a relatively new field called interventional pulmonology, which is new here in the United States and it's kind of a hybrid between some aspects of thoracic surgery and pulmonary medicine, in which we use scopes in the air passages into the chest cavity to diagnose and treat chest cancers and other diseases. And my interest is in combining some of the things that Tobias said, which is the ability to deliver novel treatments, often which involve stimulating the body's immune system to fight cancer, and then using some of these other instrument-based techniques, the scopes, into the lungs and into the chest cavity, into the pleural space, to both deliver and monitor the benefits of therapy. So I'm a plumber, but I'm a plumber that is an interest in what's going on inside the plumbing. And my goal is that we work together as a team. I think that the answers to mesothelioma are not going to come from one discipline. It's not going to be just from surgery or just from radiation therapy, just from medical oncology. So I think that pulmonologists are used to working as part of a team. We often have to take a team approach to diagnosing patients and managing them, and so that we fit in very well to the team that's going to manage patients with mesothelioma, both in the fact that we can help with the diagnosis and the staging of the disease, as well as helping in guiding the best therapies. And it's always good, I think, to have a pulmonologist on board if you're discussing, for example, surgery or radiation therapy, because underlying lung function is going to have a great impact upon whether or not a patient's going to be a candidate for an intervention. A patient may be a perfect candidate for surgery, but may not be someone who could survive the surgery from a lung function perspective. So I think our general pulmonary skills do come in handy, even though we're very interested in the scientific side.
So, Tobias, I wonder if you could just the basics. After an extrapleural lumenectomy, how does a patient breathe? Could you sort of explain, how the other lung will take over, and sort of some of the changes of, what are patients to expect following that type of a surgery?
The extrapleural lumenectomy is obviously a very invasive surgery, as you've heard in some of the previous presentations, during an extrapleural pneumonectomy, the lung as well as the pleural surfaces are pretty much excised in an en bloc procedure, so they all come out as one piece, so to speak. And what that pretty much does is not only does it mean a lot of trauma to the patient, so it's a big surgery that causes quite a bit of tissue injury and results then in has to require a lot of healing afterwards. You also pretty much lose 50% of your lung function in this context. And it's also important to know that as we all go through life, we acquire lung diseases that affect our lungs. And so if I say 50% of your lung function, you're basically left with the other half of your lung, and that may be affected by a different disease. For instance, some patients smoked during their use, and they may have COPD or emphysema, which may affect the other lung. So it may not be exactly 50% of the ideal lung function. So it really drops your lung function quite a bit and causes, in that context, your functional status to potentially deteriorate, and in some situations, patients to be left with a functional status that would be very difficult to maintain their quality of life and potentially require oxygen. And obviously that's one of the things that we try to avoid by selecting patients appropriately when we decide what surgical procedure they are subjected to, that we actually really try to preserve quality of life as best as possible and preserve lung function as much as possible with these surgical procedures, and try to do this in a proactive fashion where we actually try to select the right candidates for the right surgical procedure up front. Because in contrast to extrapleural pneumonectomy, pleurectomy and decortication, the competing surgical strategy is designed to preserve the lung, and therefore patients actually typically end up with more lung function at the end of the procedure. But I think it's important to recognize that it is a dramatic change. That being said, typically, if you have healthy lungs, one lung actually can provide pretty good function for a patient. As is actually an example for that is when we perform lung transplantations. In patients with end-stage lung disease, we actually frequently only transplant one lung, and patients can gain decent lung function after a single lung transplant.
Dr. Sturman, following an extrapleural pneumonectomy, if you develop a pleural effusion, how safe is it to insert a Pleurex catheter for draining those infusions at home?
Are you talking about on the side where the pneumonectomy was done?
No,
or the
I'm talking about the
opposite
contralateral side when the disease
I think
returns.
it's very safe. I mean, you have to use ultrasound to guide those procedures. And I think as long as you're using ultrasound guidance and the person who's doing the procedure knows what they're doing, it should not be a problem.
Okay.
I mean, the biggest concern from my perspective is that when you have a pleural effusion on the side of your remaining lung, that it's a harbinger that the disease has now recurred in the site where you only have one lung remaining, and it's a bad prognostic sign, unfortunately. So I think we can do procedures, but from a prognostic perspective, I think we have to be honest with ourselves about what it means to have that pleural effusion on that side, if it turns out to be positive, for example, for tumor cells.
And now, how do you manage, what is the rate of infections once you've inserted a Pleurex catheter? I believe it's pretty low, am I correct?
It's 5% or less in general, and most of them can be managed by a course of oral antibiotics, leaving the catheter in place.
Okay, great. Radiation-induced pneumonitis, we hear about that a lot. Could you explain a little bit about what it is and then how is it managed?
Sure.
Okay.
Yeah, so radiation pneumonitis is pretty much an inflammatory response that's caused by the ionizing radiation exposure of the lung. We really manage this with anti-inflammatory therapy. So for the most part, that involves a course of prednisone that is administered to these patients. The dose and length of the therapy varies a little bit between centers. So a lot of this is what centers have established in their experience of being helpful. But, and in addition to that, you try to provide supportive care to the patient. Obviously, we are trying to limit radiation pneumonitis also, again, when we plan therapies for these patients. And that highlights another, or again, the point that Dan already made, that this is really a team approach. And that's how we look at these patients, that this is a multidisciplinary team that's looking after the patient, where really all these specialties, radiation oncology, surgery, medical oncology, and pulmonary medicine actually come together and take care of an individual from the beginning, where we plan the therapy, and in the context of planning therapy, trying to minimize the amount of radiation exposure to the lung that's not affected by the disease, or the lung itself, and then really focusing the radiation to the surface of the lung where the tumor is, using a strategy called IMRT, is really something that you're doing up front to try to prevent these complications like radiation pneumonitis. But when we encounter it, it's an inflammatory response caused by the ionizing radiation that we then treat with anti-inflammatory agents.
I just want to comment that it's important to distinguish between radiation pneumonitis and radiation fibrosis. Radiation fibrosis is the scarring, which is often the result of radiation-induced pneumonitis that may have been treated or may not have been treated. The important differentiation is that the medications that Tobias was mentioning, the anti-inflammatories, often have their own toxicities. So prednisone and other steroids can be toxic when taken for long periods of time. Many of you who are patients in the audience have been on these drugs, and there are side effects. And if you're giving that for someone with radiation fibrosis, with fixed scarring in the lung, there is really no benefit and just harm. So it's very important to distinguish between whether there's active inflammation in the lung that would benefit from steroids and fixed scarring that's not going to benefit. And there are also some other side effects of radiation that we do see. We actually see pleural effusions on occasion, and it's really important from a prognostic perspective. We were just talking about pleural effusions on the side of the remaining lung. If you've had radiation, it's not uncommon. You get a small pleural effusion and you drain it and there are no tumor cells in it. And that is just from radiation injury to the pleura itself and not indicative of a progression of the disease. So very important to distinguish. And then we're often seeing, I can't say often, but we're occasionally seeing some patients with heart problems from radiation therapy and the complications that may arise from that, especially the pericardium, which can become stiff and limits heart function. And sometimes pleural effusions occur because the pericardium becomes stiff and scarred from the radiation therapy. So I think it's important to remember that radiation therapy is quite beneficial for a lot of our patients, and relatively few of them have serious complications. But I think as pulmonologists, we have to be aware and help our colleagues in radiation oncology in terms of managing these patients.
So I often hear from patients, or I suggest quite often that they go for pulmonary rehab. Can you talk a little bit about what pulmonary rehab means and how often you refer patients, or the type of patients you think will benefit from pulmonary rehab?
Yeah, and I think that's a very common question. Pulmonary rehab as a program is actually very similar to cardiac rehab, which is a structured exercise program where people actually get monitored and actually get taught pretty much aerobic exercise regimens, as well as some breathing techniques. So these programs run for 6 to 8 weeks and are pretty much designed to introduce patients to a regular exercise schedule and make them actually comfortable exercising, with the goal to exercise on their own. And I really liked the comment that one of the previous panelists made, actually Dr. Sugarbaker, regarding that this is kind of a athletic event going through these types of therapies. And I'm actually personally not necessarily focused on sending people to pulmonary rehab or cardiac rehab. I think the patients need to do what they're comfortable with. Everybody needs to understand that maintaining your health and maintaining physical activity through these very difficult treatments is actually very important for a good outcome. It actually raises your spirits. It kind of keeps you sane as you're going through all these treatments. And it also, I think, in my mind, has a positive effect on the immune system, on everything else in your body, and trying to figure out the best way to do that, I think it's very important. And if in that context pulmonary rehab is helpful, I certainly am happy to refer people to pulmonary rehab in this context.
I would say we've underutilized pulmonary rehabilitation, and maybe we're babying our patients a little bit, but I fully